Welcome to the ACMG Knowledge Nugget on newborn screening for Mucopolysaccharidosis type 1 or MPS I. This activity is intended for educational purposes only. Neither I nor the planning committee have any disclosures. This session is approved for 0.25 CME. To obtain CMEs for this activity, you'll need to pass the quiz with a score of at least 80% and complete the evaluation. This session is a companion to the MPS I ACT Sheet, which is available at www.acmg.net/ACT. ACT sheets are intended to be immediate resources for providers who encounter positive newborn screening results. Please keep in mind that a newborn screening result is just the first step in the diagnostic process. The ACT sheets are intended to provide an overview of the diseases identified by newborn screening and clear next steps for the management of a positive newborn screening result. This session will cover background information on MPS I, including clinical features and the underlying genetic cause, actions a primary care provider needs to take upon receiving a screen-positive test result for MPS I, clinical considerations, and supplemental resources. MPS I is a lysosomal disorder caused by pathogenic variants found in the IDUA gene, which leads to a decrease in alpha-L iduronidase enzyme activity. This change results in the accumulation of glycoaminoglycans, or GAGs, in the body's lysosomes. The accumulation of GAGs causes cellular dysfunction, leading to enlarged tissues and organs. The presentation of MPS I is clinically variable and was historically divided into three separate types, known as Hurler syndrome, Hurler-Scheie syndrome, and Scheie syndrome. But because there is so much overlap between the three types, MPS I is now currently divided into two types, severe and attenuated, based on the age of onset and symptoms. Severe MPS I may initially present with an umbilical or inguinal hernia. Later symptoms may include coarse facial features, hepatosplenomegaly, and corneal clouding leading to vision loss. Individuals with severe MPS I often also have multiple skeletal abnormalities and exhibit developmental delay. Initial signs and symptoms usually arise within the first year of life. Signs and symptoms of attenuated MPS I are similar to those seen in the severe form, but are usually milder, and signs like skeletal abnormalities, coarse facial features, or intellectual disability may be absent altogether. Attenuated MPS I typically does not present until later in childhood. MPS I is inherited in an autosomal recessive manner, meaning that only babies with a pathogenic variant in both of their IDUA genes will be affected. Parents with a child with MPS I are carriers and are unaffected, but have a 25% recurrence risk with any future children they have together. At this time, not all states provide newborn screening for MPS I. A good resource for checking a state's newborn screening panel is the newbornscreening.hrsa.gov website. In the states that do screen for MPS I, testing is mostly accomplished by examining levels of the alpha-L iduronidase or IDUA enzyme, which is decreased in individuals with MPS I. Some programs also examine the levels of GAGs as a second-tier test to help improve screening and rule out cases of pseudodeficiency. Pseudodeficiency is commonly seen in lysosomal disorders, including MPS I, and is caused by certain known variants in the IDUA gene. Pseudodeficiency means that a baby's IDUA enzyme levels appear low upon testing, but this decreased activity does not cause disease. These babies do not have and will never develop MPS I. Babies with MPS I pseudodeficiency will have normal GAG levels. Now that you have an understanding of what MPS I is, let's talk about what to do if you have a patient screened positive for MPS I during newborn screening. You'll need to take the following actions. First, contact the family and do the following. Inform them of the newborn screening result. Ascertain clinical status. Clinical signs may not be present in the neonatal period, though some infants may have hepatosplenomegaly. Umbilical or inguinal hernias may also be seen in babies with MPS I, though they are also commonly seen in newborns generally. Provide the family with basic information about MPS I. Second, take a family history. Because MPS I is inherited in an autosomal recessive manner, it is common for there to be no known family history of MPS I. Third, arrange a referral to an MPS I specialist for genetic counseling, a comprehensive clinical evaluation, and discussion of treatment options. The specialist could be a pediatric genetic, metabolic, or transplant specialist. The clinical evaluation should include a comprehensive physical assessment by an experienced MPS I specialist. Fourth, working with the appropriate specialist, take steps to ensure biochemical and/or molecular confirmation of the newborn screening result. Confirmatory testing includes IDUA enzyme analysis, GAG analysis, and IDUA gene analysis. In some cases, results of this testing may help determine the MPS I type. Fifth, report the final diagnostic outcome back to your state newborn screening program. Current treatment options for MPS I include hematopoietic stem cell transplantation and enzyme replacement therapy. As you continue to care for your patient with MPS I, it is likely additional questions and concerns will come up. Here are some resources where you can obtain information on MPS I, appropriate laboratories and tests, and genetic specialists. Before we end today's session, let's have a quick review. First, MPS I is a serious condition, and identification of affected individuals is essential for administration of early treatment. Second, newborn screening may identify both the severe and attenuated forms of MPS I. Third, ACT sheets are available on the ACMG website to review in the event of a screen-positive result. In addition to MPS I, ACT sheets are available for many other conditions that can be identified through newborn screening.